Well, welcome and thank you for joining us for this virtual UMiami Health Talk. Care doesn't end, hospice and bereavement support for patients and families. I'm Emmy Award-winning communications expert Ann Keel-Dux, your moderator for this evening's webinar, presented by Sylvester Comprehensive Cancer Center, part of UHealth, the University of Miami Health System. Sylvester is one of only 73 NCI designated cancer centers in the nation and is ranked among the top 50 cancer centers in the country by US News and World Report. And this recognition reminds us that leading care extends beyond medical treatment to the emotional journey as well. August is National Grief Awareness Month, making tonight's conversation especially meaningful. And we will hear from experts, Doctors Mariana Khawand-Azoulai and Wendy Lichtenthal. They will provide an overview of palliative medicine and bereavement care and the types of support available. At the end of the presentation, you can participate in our Q&A session, a unique opportunity to ask direct questions to our experts. Now it's my pleasure to introduce our first panelist, Dr. Mariana Khawand-Azoulai, the Medical Director of Inpatient Palliative Medicine at Sylvester and Assistant Professor of Clinical Medicine at the University of Miami Miller School of Medicine, where she leads the Hospice and Palliative Medicine Fellowship Program. She is known for her compassionate, multidisciplinary approach to supporting patients and their families navigating complex medical needs. Welcome, Doctor.
Thank you so much for that warm introduction. I'm going to go ahead and share my screen. 1 second, please. And I'm so honored to be here tonight, and I'm so happy to see what a great turnout. I'm going to go ahead and start the slideshow. So I am a palliative medicine physician, and I also do some hospice care as well. And I'm hoping that today we can help define palliative care better for our audience. We can also talk about hospice care and what that entails. I'm hoping to dispel some common myths about hospice care that can sometimes create barriers to entry to hospice care. And then finally, I'm going to end with a review of the benefits of hospice care for both patients and their caregivers. So first, the definition of palliative care, my life's work and my passion. So palliative care is a specialty that focuses on providing relief of suffering for patients with serious illness. Serious illnesses like cancer. We focus on alleviation of pain and symptoms, and we also take a whole person approach to the patient. We do this through team-based interventions. So it's not just a physician. A good palliative care team should also have APRNs and PAs, social workers and chaplains, psychologists, and other individuals who can really provide comprehensive addressing of this suffering that patients go through with serious illness. It's really important to understand that palliative care can begin at any age and any stage of cancer or serious illness. So palliative care is not just end-of-life care. And we'll talk a little bit more about how it differs from hospice care. So what can someone expect when they're referred to a palliative medicine or palliative care specialist? Well, it's specialty care. So the same way that if you told your doctor, I've got lots of acid reflux, they would refer you to a gastroenterologist. If you have a lot of symptoms like pain or side effects like nausea and vomiting from your cancer or cancer treatments, your oncologist may refer you to a palliative care specialist. In other illnesses like ALS or Parkinson's, patients get referred for their symptoms related to those illnesses as well. Palliative medicine is provided in office setting as well as a hospital consultation. Palliative medicine teams and specialists provide pain management, symptoms including neuropathy, poor appetite, nausea, and vomiting. Another big area that we focus on is advanced care planning. This is really about, documenting and learning a patient's wishes and values around the kind of medical care that they would or would not want should their condition deteriorate. And I think, it's one of the most beautiful things we do because it's not just about completing a document. We really get to know our patients. We ask, what's important to you? What do you value? as you go through your cancer journey. What is an acceptable quality of life? And we document that, we communicate that with the patient's teams. And again, patients can be on curative and aggressive treatment when they are seeing a palliative care specialist. So is palliative the same as hospice? I've already alluded to the fact that it's a bit different. So there's a lot of confusion around this, even amongst physicians and nursing staff and other people who work even in healthcare. Hospice care is really a special kind of palliative care. And the focus is on the quality of life, much like with palliative care, but it's really for the advanced stages of illness. Hospice care provides care for people in the last phases of incurable disease so they can live as fully and comfortably as possible. And in general, hospice care is provided when patients are no longer receiving treatments for their cancer or their serious illness. In general, this happens in the cancer world when there are no more treatment options, or when treatment is causing more harm than good, or when a patient has decided that they no longer want to pursue treatment for their cancer for whatever reason, whether it's quality of life issues or burden. So what exactly is hospice care? So it's not really specialty care where you go to a clinic. It's an insurance benefit. And it's this holistic care with medical, emotional, and spiritual support. And in addition, hospices provide care in the patient's home or wherever the patient lives. So if they live in a nursing home or an assisted living facility, there's 24/7 phone access to nursing assistants if the patient has a symptom or a concern. They provide durable medical equipment to the home, and they also provide different levels of care as the patient's condition progresses. And the hospice benefit is really for patients who have a life expectancy, an expected life expectancy of 6 months or less. There are patients who are on hospice for longer than this. Jimmy Carter is an example. So the different levels of hospice care are seen here. Routine hospice care is provided in the home or wherever the patient lives, and it consists of the patient having a team assigned to them, a nurse that will come and visit once or twice a week, depending on the patient needs, a home health aide, providing custodial care, which is like helping with bathing and dressing if needed. If the patient doesn't need that, then they can refuse that part. Routine home hospice care includes all the durable medical equipment and all medications related to the patient's illness. So if they've got pain, the pain medicines will be delivered to the home. In routine hospice care, there's not somebody at home 24/7 with the patient and the caregiver. It's just a little bit of extra support. However, if that patient becomes very sick or starts to have a lot of symptoms, they can call the 24/7 phone number and potentially qualify for what's called continuous or crisis care at home. Continuous or crisis care at home is for patients who are having acute symptoms or patients who have entered the acute dying process, meaning they're in the last hours to days of life. And with continuous care, there is a nurse at bedside almost 24 hours. A physician will come in once every 3 to 4 days to check on the patient, and medication adjustments are made on a daily basis as needed. With routine care, going back to the physician visit, routine care, a doctor will come about once a month to check in on the patient. And then finally, there's inpatient hospice care, which is for patients who are too unstable to go home or who are requiring medications that cannot be administered at home. If a patient is on routine home hospice care and then they're on continuous care and the symptoms aren't being well managed at home, then they qualify to go into what's called an inpatient hospice unit. There's another kind of hospice care called respite care, which is not on this slide. And that is for if a patient's caregiver needs to leave town, then the patient can be also brought into an inpatient hospice unit for a short amount of days for some respite care. So a little bit of myths versus facts on hospice. So these are just some of them. I couldn't cover all of them. This would take 2 hours, but some of the big ones are, that hospice means giving up. And, the truth is that hospice is a focus on comfort and dignity and living life as fully as possible despite serious illness, despite inability to cure the illness. And it's definitely not about stopping care. We continue to care for the patient. I always tell patients, I tell other doctors, hospice doesn't mean do not treat. So I think that's a very important point. Another myth is that hospice is really for the last few days of life. So often I have patients who qualify for that hospice benefit, for the help at home, for the 24/7 access, for the medicines being delivered at home, but they tell me, Dr. Khawand, I'm not dying. I don't need this. I'm not dying. You think I'm dying tomorrow? And so it's really, I re-explain it's the 6 months or less prognosis. And while we hope you live even more than 6 months, your overall condition, with your overall condition, you do qualify for the hospice benefit. Another big myth is that you have to stop all your medications and leave your doctors. That is not true. If someone has on medicines for diabetes, hypertension, HIV, and they're on hospice because of cancer, those other medicines continue. We even treat infections on hospice sometimes if it's appropriate and if it will improve quality of life. So that's a big one for a lot of people. Another myth is that hospice is a place, and as I've already explained, it's really a service provided in the patient's home. And then this one is a big one. Hospice means you will be sedated or given medicines to accelerate the dying process. This is a very real fear. And, in the United States of America, we are not allowed to hasten death. That is not a practice. It's not within our ethical construct or our legal construct of medicine. And we've actually have some data that shows that patients, if you take two of the same exact type of patient with the same exact cancer, those who receive hospice care can live longer because they're at home, they're not in a hospital. There's so much more at the end of life, there's so much more to living longer than medical interventions. So again, hospice doesn't hasten death, and we do use strong medicines like opioids, but they're only used to control pain and shortness of breath and other symptoms. They're not used to sedate a patient. And if the patient's goal is to be as awake as possible, interact with their loved ones, then we focus on, managing and balancing pain relief with sedation. So some of the benefits of hospice for patients, of course, better symptom control because you've got this entire team of specialists with usually a board certified fellowship trained hospice and palliative care physician leading the team. Fewer hospitalizations, this is a big one. I can't tell you how many of my patients tell me, I just don't want to come back to the hospital. Having this team that can deliver medicines to the home, having this team that can come and assess the patient in their home leads to fewer hospitalizations. And this is one of the biggest benefits of hospice for many of my patients. Quality of life, of course. We're focusing on the human being. We're not looking at numbers. And people being at home is often what quality of life means to them. And then finally, as I've said already, living at home. So majority of hospice patients are able to remain in their preferred setting, which is the home. Hospice also has caregiver benefits. So not just the patient, but the caregiver. And for many years, we look at medical literature and it's all about the patient and patient outcomes, but of late recently, we've been looking a lot at caregivers, and caregivers carry a lot of burden, especially closer to end of life for their loved ones. So hospice actually does an incredible job of supporting caregivers. Families feel less stressed and more supported. There's emotional support through counseling. The social workers on the team are oftentimes excellent at counseling. There's the opportunity for respite care, as I mentioned before. And there's 24/7 access to guidance. People don't feel lost. People feel that they can pick up the phone and get help at any time. For those who are spiritual or religious, there's also it's a Medicare requirement that there's a chaplain on the team. And chaplains can really do an incredible amount of counseling for both patients and caregivers to help find meaning in this senseless illness. So that can be extremely helpful for the emotional support piece. Preparedness. Caregivers feel confident in managing the dying process when hospice is involved. Improve mental health because of all of this support. We know that we've seen data that patients who are enrolled with hospice, their caregivers actually have a lower risk of prolonged grief and lower risk of depression. And finally, bereavement support. So by Medicare mandates, hospice has to provide bereavement support to the loved ones or caregivers of the patient who has passed away. And the reason for the 13 months is because oftentimes it's that 1 year anniversary of the patient's death that is so hard for patients, for caregivers, I'm sorry. So that extra month gives people time to follow up and ensure that patients are connected with grief and bereavement support. So I've had many patients in my, I do a palliative care clinic. I have a palliative care clinic and I also do palliative care consults. And I've had so many patients tell me, well, Dr. Khawand, I love you. You're great. Or they'll tell me, why can't I just stick with palliative care? Why do I need to go to hospice? And it's not go to hospice, right? So I always help them understand that. And sometimes people have stigma with the word hospice. They've had a bad experience in the past, or they feel that they really feel that it goes against what they want because it feels like giving up. So this helps me drive this point home of the difference of what a palliative care specialist can provide and what hospice can provide. So I tell the patients, I'm a palliative care doctor and I see you in my office and then you leave, right? And when you have a crisis at home, I'm not on call 24/7. I don't provide medical equipment to your home. I can't visit you in your home, unless you're my neighbor, maybe. So I oftentimes will, of course, I want to support those patients and I continue to support them through once they've enrolled with hospice. Because one of the other myths is that you can't keep seeing your doctors, but you can. But I always encourage those patients to see that the hospice benefit will provide them a lot more than a palliative care specialist can provide. So the key differences here again with palliative and hospice care, timing is one of the biggest differences. Palliative care, any stage, even for curative patients, because we're symptom management experts. We can help patients along that journey. They don't have to have a kind of estimated prognosis of 6 months or less, but with hospice care, they do. The other big piece is foregoing treatment related to the illness. So foregoing treatment related to the cancer. Hospice will not cover cancer treatments. And whereas a patient who's seeing a palliative care clinician, their insurance will continue to cover cancer related treatments. And one of the biggest key differences on the bottom here is the support, the level of support. While palliative care doctors try their best to support their patients, hospice care is really a robust support system in the patient's home that can't be paralleled by what we do in palliative care. So my final points are that all hospice care is palliative care, but not all palliative care is hospice care. If somebody is considering hospice care and unsure, certainly a palliative care team can help discuss goals of care through that skill set of whole person care and understand if hospice is right for them. So maybe they're not plugged into palliative care early on and they're not seeing palliative care already. This might be a good time to see palliative care. If there's a decision point around hospice, we can definitely help. But the ideal state is that we have early visits with palliative care, because when you do that, we can support patients alongside their cancer, improve quality of life, help them live maximally in the face of cancer, and ensure that values and wishes are known and honored. And finally, hospice care provides many benefits to both patients and caregivers, including the very important bereavement support once the patient has died. And that is it. Thank you for your time.
Thank you, doctor, for providing such clarity on both hospice and palliative medicine, and obviously your thoughtful approach as well. Our next panelist is Dr. Wendy Lichtenthal. Dr. Lichtenthal is the director of the Center for the Advancement of Bereavement Care at Sylvester and a licensed clinical psychologist with more than 20 years of experience leading innovative grief and survivorship interventions in oncology. Her research focuses on developing evidence-based approaches like meaning-centered grief therapy to support patients and families coping with loss and post-treatment transitions. Welcome, doctor.
Thank you so much. I'm just going to share my slides here. Okay. Well, I am so grateful for that introduction, as well as the opportunity to share with everyone today, and picking up where Dr. Khawand left, talking about the emotional reactions that happen as part of the journey when we are talking about palliative care and symptom management as well as hospice. So Dr. Kwan had mentioned that part of hospice care is bereavement support. It's actually this mandated part, mandated by Medicare. But surprisingly, as much as the idea of loss is very much part of the cancer journey, bereavement support is not a mandated part of cancer care. And at Sylvester, we're trying to address this. We really believe that care doesn't end when a patient dies, and we want to emphasize this point by providing support such as this presentation here to make sure that patients, families, their caregivers, people understand that there is this continuity of care from end of life through bereavement when that is part of the picture. So on the slide here, you'll see something that Dr. Khawand was referencing, which is that palliative care really can start at the moment of diagnosis with a disease like cancer and be in parallel with cancer treatment. But what might happen over time is there's this shift in emphasis where cancer treatment, curative treatment diminishes and palliative care becomes more of the emphasis toward the end of life. Well, that shift in emphasis is something we're thinking about in terms of bereavement care as well. We want the presence of the hospital, the institution that cared for the patient, to be very much connected to caregivers and families after a patient's death. But we also understand there's going to be this shift in emphasis because over time, really, what we want for caregivers and families is to feel held by their communities, to know that the institution that cared for them is still there, but eventually help support their integration back into their lives. So we're doing a lot of this work through the support of Sylvester's Center for the Advancement of Bereavement Care. I'll say a little bit more about what we're offering toward the end of this presentation, but broadly speaking, this is our initiative to make sure that we have supports for patients, caregivers, and families wherever grief is present. And again, that begins before the death of a patient, but certainly continues for families who need that kind of bereavement support. One very important facet of our work is that it is evidence-based, that we are trying to take research that we do and build it into the care that we provide, as well as into the training that we provide other care providers to make sure that they are grief-informed in their practices. And we're advocating for resources in this area because it often doesn't get the same attention, understandably, because it's difficult to talk about. It's difficult to put on a banner. And we're so grateful that Sylvester is understanding the importance of having a place for this type of care. So as I mentioned, our goal really is to support grief throughout the cancer journey, understanding that grief really often begins at the time of diagnosis. From the moment that someone gets a diagnosis, it could be grief over plans that were made, things are derailed, but those losses bring up grief. And so there are the losses that are part of the cancer experience, and then there's the threat that lingers, that can bring up grief around the possibility of losing someone close to you. But along the way, there are so many losses to acknowledge, losses for patients, losses for caregivers and their families. There's the loss in physical functioning that patients face, a loss of independence, work and other important roles, physical appearance, changes to one's sense of identity, sometimes a loss in faith, and plans for a future. And with these losses come grief. So even when we're not talking about end of life, we want to acknowledge that grief is in the picture, and our services support this along the disease trajectory. So what falls under the umbrella of grief? Well, certainly very key to grief is yearning, is wanting what was, or if this is grief over the loss of someone significant in your life, yearning and missing them, of course. But there are all these other feeling states that come up that we can understand are part of the grief response. And that includes shock and disbelief, certainly anger, worry, guilt, sadness, fear, anxiety, anxiety and worry often about continuing to feel this way and feel all of these feelings about a future that will be filled with these kinds of experiences, a loss of meaning, a loss of a sense of identity. And sometimes with the overwhelm of all of these feelings, people can just feel numb. And it's important to understand, as I've already alluded to, that while certainly when we talk about bereavement, we're thinking about death losses, there are so many non-death losses that are part of the picture where grief is going to emerge. And these can be along the illness experience, along the cancer journey, in the here and now, in current losses. But we also, our minds are creative thinkers, and we can anticipate losses, some that do happen and some that might not happen. But we want to acknowledge that anticipatory grief, that kind of grief where we are wondering if we will lose something, and how painful and powerful that kind of grief can be as well. So part of what we're doing here by doing these kinds of presentations, these talks, is to give a background and an education. This is part of the support and offering. And when we think about how to support individuals who are coping with grief and loss, or who may cope with grief and loss in the future, what can help the most, among the things that can help the most, is to just know more about how grief and loss operates, what is common. This becomes the frame. Because so often what people struggle with, among the things they struggle with the most, is not understanding what's happening to them emotionally. What is this? Grief can feel so chaotic. It can feel so foreign to us. And so what we want to do is give some frames right now, insofar as this can be helpful for people coping with grief, to help them understand that whatever they're experiencing right now, it makes sense. Your reactions to loss always make sense. So what I want to do now is just move into some frameworks that we think of, kind of contemporary perspectives about grief and loss and bereavement, that can be helpful in thinking about what someone might be going through. First, let's talk about attachment. How we attach, how we connect, affects how we respond to loss. And we know that our attachment responses, how we attach, is hardwired in us. We are wired to attach and to connect. This is part of what promotes safety and survival, is our connection to other human beings. And we are also wired to protest separation. That is kind of buried in us, hardwired. And what becomes important with this is that the responses we have, because they're belly level, because they are so much ingrained in us from the moment we are born, the moment that we attach, a lot of our responses might not feel rational. And so I have this image here of a child. And if you look at this child and you see, and you can imagine this child, let's say this child was with their primary caregiver, and that primary caregiver just left. This could be a separation distress response, what that separation feels like. And if you look at that child and you see their face, you can see anger in there. You can see rage. Don't leave me. Please, please, please don't leave me. And you can also see fear. Please, please, please don't leave me. Please. That is our separation response. That is what it is to grieve. And that is where we come from when we've lost someone or something to whom or to which we're attached. So that framework is so important, because a lot of our grief responses don't feel rational. They don't feel even adult-like. And that's because they're not. They're coming from that belly level, and that can help us make sense of our responses. It's important to remember that fear and anger are part of grieving. And so that framework can help us make sense of our response. Another thing that people often react to or wonder about is why they're reacting so strongly to a given loss, something that might surprise them. And again, this could be a relationship, losing a person who is significant in their life, but they don't know why they're responding as intensely as they are, or losing something else along the cancer experience, such as hair loss that occurs. And people are wondering, why is this so strong for me? Again, your reactions always make sense. And we think of grief as proportionate to the nature of how attached or connected we are to a person, to something about ourselves. So again, using that perspective to help make sense of your responses is a way to cope. Another frame that we want to keep in mind is the fact that grief is nonlinear and it does not end. A lot of people, what's been very much popularized is the stage model of grieving. And so a lot of people come to their grief experience having heard about the stages of grief. What we know in kind of our contemporary thinking of about grief and bereavement is that there aren't these set universal sequenced stages that we go through with grieving. Our emotional reactions overlap, they're messy, grief is muddy. And what really often happens is that waves of emotion come. We are reminded about a loss and then a wave comes. And so because of that, there's not this linear progression of feeling better or intensity of grief diminishing. That's just not how we operate. And why that's important to say, why it's important to say there aren't these set stages is because people do so often self-assess and wonder what's happening here. Or if they were feeling better, I'll put in quotes, and then a wave comes, wondering, if they've had a setback or a regression. Nope, that's just grief. That's how we grieve. It comes in waves, it's unpredictable, and it doesn't end. That doesn't mean that we feel a state of chronic, persistent, severe distress every moment of the day. It's not to make that seem scary, but rather that we should not be surprised that with a reminder, which could be so far out from a loss that you experience, that those feelings of grief can emerge again. There's no resolution or end point. We don't recover. And I even hesitate using words like healing, even though I know so many people do, because it suggests that there's something that's done. Grief isn't done. And related to that, especially when we're talking about death losses, when you've lost someone significant in your life, those relationships continue. When you've been so affected by someone, they've been central in your world. When they die, we don't expect that that relationship ends. So we say this, and this framework is important because people often question, they find themselves talking to someone who has passed away and wonder, am I crazy? Is this odd? No, because our relationships continue, wondering what would they say or what would they feel about this situation. That is part of relating to them, and that relationship, albeit transformed, absolutely can continue in helpful ways after we lose someone important to us. Another frame that can be helpful is thinking about the way that we naturally do move through grief and the way we adapt. And one model of this is acknowledges that there are kind of these two major spheres that we move between. One is focusing on confronting the pain of that loss. And the other is trying to figure out, well, how do I exist in this world without this person or without whatever was lost physically here with me now? And that process of figuring it out and re-engagement is also part of adaptation. But perhaps one of the most important things when we think about this model of going back and forth between these two modes is this line here, this jiggity jaggedy line that looks like it has no order to it and no predictable sequence. And that is because that's grief. As I was just saying before, grief is nonlinear. And the way we operate is that we go to that place of pain, and then we move to a place of figuring it out. So this frame can be so helpful because grief can feel so unusual and different in that way, that we can be weeping and leaning into that pain in one moment and 30 minutes later laughing with someone. So oftentimes people are like, what is going on with me? Am I crazy? Or why do I feel okay, but then not okay, and then okay again? That's grief. That's how we adapt. We go back and forth between the two. And that frame, again, is another way of making sense of your response. Another point that we always want to emphasize is acknowledging the natural tendency we all have to avoid pain. We don't like to be in pain. It is natural to be driven to try to get away from the pain of grief, the distressing thoughts, the memory, the images. And so people do that. They move away from that pain and they find a way to dose themselves. We find a way to kind of take it in and then step back. And sometimes that is with a mindfulness and intention, and sometimes it's on automatic. So we acknowledge that back and forth, as I was just talking about, those kind of two modes and that dosing. But we also want to be careful to think about the cost of chronically trying to get away from pain. So I do want to acknowledge that something that we also want to support is having a space to touch down on those feelings and and process the grief and pain. So while we understand there's a back and forth, we also want to make sure that people can find a way to process their grief and pain when that is something that needs attention. So chronic avoidance can be problematic. But really, since there is no right or wrong way to do this, the kind of dance of grieving, being flexible is one way to think about the how. How do I do this? Well, be flexible. Since there is no exact way to be with pain, it's not that at 10 o'clock at night, that's when you go and think about your loss. Rather, it's looking at the context. Sometimes it's helpful to share, but it's not if you're going to share with people who don't get it or are going to say things that are unhelpful. So then in that moment, it's not so helpful to share. Sometimes it's helpful to retreat and kind of be alone with your pain, except when it's not. Sometimes other times, you might feel like I need some company right here. I need companionship in this. I need a witness. I need someone who gets it. So there is no prescription for how to grieve, but keeping in mind this idea that I can be flexible and figure out in this given context, in this moment, when I have this on my plate, or I have to deal with these logistics, or I want to do something that matters to me right now, and I know it's going to bring up a lot of feelings, so I want to kind of focus on this other thing that matters, and then I'm going to give those feelings attention later. Those when and when nots are things to keep in mind in terms of the how to cope with all of this. Another frame that is so important in all of this is understanding how we as human beings are driven to make meaning of loss, driven to make meaning of really all adverse experiences, including cancer. We want the world to make sense. We want it to feel safe and predictable. And that is why our brains go back and say, wait, how did we get here? Why is this happening? Why me? Why them? How did we get from A to Z over here? Because we want the world to make sense. And so we often struggle to kind of figure out how did we get here and what now? So that if you're observing yourself struggling with that, understanding that that drive is very much real and part of what we do as human beings can help you make sense of that kind of review that we often go through, review of what happened, review of our own role in what happened. We are also driven to make meaning of our lives. So when we think about losses, and again, specifically when we're talking about the loss of someone who has been central in your world and central to what gives your life meaning or gives you a sense of purpose or how you know yourself, how your sense of identity is formed, it is natural to feel that sense of meaning, identity, and purpose challenged and to ask yourself, well, who am I now and what is my purpose and can life feel meaningful again? So all of these frames that I'm giving really are to help make sense of the chaos that is grieving. And again, that grief can come along the cancer journey for patients, caregivers, and family members, and then certainly for caregivers and family members after someone has died. So how can you cope? Well, first, let's go back to what I've just been saying. Validating, normalizing these responses in what can feel so chaotic and leave you feeling lost, and understand, wait, no, this is what we do when we lose. This is natural, typical responses to loss is one way to cope, is to give yourself that frame and keep in mind the different models that I just went over. And in all of that, allowing the thoughts and feelings to give yourself permission and say, of course I feel this way. Look at what just happened. Because we know when we try not to think about something, some of you might be familiar with this experiment of a pink elephant, not to think about a pink elephant. So some of you may have heard someone say, try not to think about a pink elephant. Well, the pink elephant effect is the more you try not to think about a pink elephant, the more you're thinking about a pink elephant. And so is that the case with our thoughts and feelings that are upsetting or distressing or disturbing. If we find ourselves trying to push them out, we are giving them attention, and they actually can feel louder and stickier. So instead, allowing them and kind of giving that permission is a way to cope. We also can use mind-body approaches to help us be present with those feelings. Grief so much is a part of thinking about what was in the past and worrying about a future without whatever has been lost or whomever has been lost. What mind-body approaches offer us is a way to come back to the here and now, come back to the present. And so things like mindfulness meditation, deep breathing, progressive muscle relaxation, massage, acupuncture, exercise. When we engage our senses, we are necessarily coming back to right here, right now, and that can be really helpful in managing the intense feelings that come our way when we are grieving. I want to kind of put in a plug for sharing with the asterisk, the caveat that of what I mentioned before, which is sharing in helpful context, right? So sharing with people who have capacity to hold what we are sharing, who are able to support that and listen in ways we need, who we feel like get it. And so that power of sharing, of having a witness, can be something that can really help people cope. I say this and I punctuate it because it also means going there. And again, this idea of the pain is something that people can have a lot of mixed feelings about. If I share it, I'm talking about it, I'm thinking about it, I'm going there, and that's scary. At the same time, ventilating and letting it out can be so helpful. But as I was just alluding to, we need different kinds of supports. And so part of coping with loss is figuring out what you might need in terms of support. Different people need different things. And so when we look at this pyramid here, this is like a public health model, we can think of some people needing kind of general information and support. That's what we're offering right now in this presentation, is information and acknowledgement. And then other people might need a little bit more. They might need more scaffolding. They might want to get connected to a support group or have individual peer support, or get a few counseling sessions or educational sessions that are more specific. And then others might really want more professional support. They might feel like they need, or others might feel like they could use more targeted support in that way. So we want to acknowledge that different people need different things. And we also want to acknowledge that what you need may change over time. There are times in our lives where attending to grief might not just be practical or doable. And then there's an open space and psh, a wave comes and you're like, I think this needs attention now. So again, just normalizing that fluctuation, even having space to be with this kind of pain, is something that we want to acknowledge. Finally, I want to give attention to this idea of finding meaning in your losses and in your life, which I alluded to is so often a struggle for people who are grieving. We want to say that thinking about the lens that you see the world through, we all come to our losses with different belief systems, with different ways we make meaning. And however you're responding to your loss makes sense. So it might be through spiritual beliefs, it might be through beliefs about yourself and how you cope with things. All of these are going to affect how you make sense of the loss itself and your own way of being with it. So being compassionate to that, especially when you're noticing differences, say within your family or with others who have experienced a similar loss, what you come to your loss with might be very different, is going to be very different than the person next to you. But even though we might have these kind of more automatic responses to our loss, we want to empower individuals to think about the choice they have and how they make meaning. You have agency in the way you tell the story, the way you think about things, and that is so important as well. Because ultimately, this Carl Jung quote, things don't have meaning until we supply the meaning. We're in charge of that story. And so part of what we can do, and also what it is when we're sharing with people, is we're kind of helping to create that narrative and think about what ways of making meaning of these losses might be most helpful to us. Because we can also borrow this quote from Viktor Frankl, everything can be taken from a man but one thing, the last of human freedoms, which is to choose your attitude in any given set of circumstances. So this idea here is acknowledging what can feel so out of control really throughout the cancer experience. And certainly when we experience loss and the loss of someone so significant and close to us in our world. So we can't control what's happening to us, but we can choose how to respond to that. And so helping people to think about where they have agency in these out of control circumstances is another way to think about coping. And some of that is choosing about how you tell the story, the narrative, and some of it is choosing who you want to be and how you want to respond. Frankl references this Nietzsche quote, "He who has a why to live for can bear almost anyhow." Some of you may have heard this quote before, but we really lean into this when we think about coping with grief and loss and adversity at large, because if we can tap into your whys, what matters to you, that can help fuel you and help buoy you through the most difficult of feelings, including grief. So when you're grieving, thinking about what those whys are can be so central. When you feel like you're drowning in your grief, when you feel like you're lost at sea, your whys can become your lighthouses. They can be what you steer your ship toward so that you can find a way to put one foot in front of the other, literally or metaphorically. So kind of the charge becomes thinking about, what are your whys? What are the things that matter to you, that keep you going? Are they other people in your lives? Is it your faith? Is it a cause that you are active in? Something and if it is related to someone who you lost, who is no longer physically here, it might be about carrying their legacy forward. That can be your fuel. Those are your lighthouses. And so we want to support people in staying connected to or reconnected to these sources of meaning and purpose in their lives as a way of coping. And think about and give space for reflecting on ultimately who you want to be in the face of whatever losses you might be confronting. Because I am not what happens to me, I am what I choose to become. This idea ultimately that in these situations that might feel so absolutely against the plans you had for your life, thinking about how you choose to respond and who you want to be in the face of them is what you have control over. Now, I want to conclude by coming back to resources that we are offering at Sylvester, resources for patients, families, and caregivers at Sylvester, but certainly the community at large. We are here to provide supports for grief therapy referrals, connection to community grief support, as I mentioned before. Ultimately, we want people to find their place back in their world, back in their communities. We have memorial events. We have counseling and support groups that will be starting up hopefully soon, peer support, and online education just like this. Some upcoming events in service of that. Next week, we have a webinar in recognition of National Grief Awareness Day, which is August 30th. On August 29th, we will have a webinar on ways of finding support, getting your support needs met. We know that that can be a real challenge when we're grieving. And we also will be hosting Together We Remember Memorial event, a virtual ceremony. So please contact us if you have any questions at all about these events, resources, or just want to figure out what kind of support you might need. Thank you so much, and I look forward to answering questions.
Well, thank you, Doctor, for your guidance in supporting families through grief. Now let's launch our Q&A session so our experts can answer your questions. Our first question is for Dr. Khawand-Azoulai. How effective are current pain management options in keeping patients comfortable while minimizing drowsiness or other unwanted side effects?
Thank you so much for that question. I think any palliative care team and hospice team is going to address with the patient what their goals are first, and will optimize non-sedating medicines first. So we do have effective pain medicines that have zero sedation. And then we also have opioids, which are appropriate and useful in the palliative care and hospice setting. We can always start very low doses and titrate up. and avoid sedation, monitor for sedation, etc.
Thank
Thank you.
you. And Dr. Lichtenthal, can you tell us about how caregivers can balance grief with ongoing responsibilities, such as caring for other family members or children without feeling isolated or overwhelmed?
Well, I guess the first thing I would say is it's hard not to feel isolated and overwhelmed when you're juggling so much. And so normalizing that experience and not thinking you're doing something wrong, I think is part of the response of how to cope. Again, I'll reiterate that point that so often people are struggling with wondering if they're not doing it well, they're not coping well. And in fact, when you have so much going on that is stressful, it is normal and typical to feel stressed, to feel overwhelmed, and to feel like others don't get it. But we can think about ways to find people who do get it. So finding supports, individuals who might have gone through it. So being connected to other people who have experienced caregiving and understand what that juggling can feel like. Going to support groups, although we understand very much for caregivers, finding time to do these things for yourself can be so hard. So another thing I would say is part of helping caregivers to find support is helping them maintain that metaphor of the oxygen mask, right? It's so often hard to think about, well, that's for me to go to a support group or to go connect with someone or go on a walk and do things that give me space. But if you adopt that metaphor of, putting on your own oxygen mask and before you serve others, or a way of thinking about recharging your battery in service of caring, in service of helping out the person you're caring for or other family members, if you're juggling multiple caregiving responsibilities, that can be something to consider as well. Professional support and having a space is also something definitely to consider. We know that caregivers are often protecting a lot of different feelings. And so really expressing what they're actually experiencing or what they're actually worried about might be hard to do. So again, finding those protected spaces and individuals where it feels safe to say what's hard and where you're not going to feel guilty for saying this is hard is really important to do.
Thank you. And our third question is for Dr. Khawand-Azoulai. Can patients receiving palliative care still receive treatments that might lead to remission or a cure?
Certainly. While the majority of my clinic patients have stage 4 or more advanced cancers, there are patients who are receiving curative intent treatment that I also see in clinic. One big example is head and neck cancer patients because they receive both chemo and radiation at the same time. They have such a high symptom burden from that. So we treat their pain. We use opioids oftentimes. We also develop a treatment plan to get them off of those opioids once they've been cured.
Thank you. And Dr. Lichtenthal, how can parents and families navigate bereavement after losing a child? And what resources exist for pediatric loss specifically?
Um, the loss of a child is so hard for people who have not been through it to comprehend. And so we were talking moments ago about that sense of isolation. And so really finding connections to other grieving parents can be such an important part of the journey. A lot of the ideas that I was alluding to before about coping definitely apply. We know that the challenges to parents' sense of meaning and identity and purpose and the drive to make sure that their child is not forgotten, that their life mattered, is such a part of what they may be contending with. I will say that we have lists of resources available on our website and we do a lot of work specifically with parents. So if people are looking for specific supports, someone who has lost a child, please do reach out to us. We can help find tailored supports for you, whether that is counseling or other kinds of ways of connecting to other parents to help parents feel less alone in this.
Thank you, doctor. And Dr. Khawand-Azoulai, can patients continue to get treatments like antibiotics or IV fluids when on hospice?
Thank you for that question. Yes, certainly on a case-by-case basis, patients can get things like antibiotics and IV fluids if they're within the goals of the patient's care, if they're not going to cause more harm than benefit, then those interventions can be offered. There are hospices that even offer blood transfusions for symptoms. So if patients have a lot of shortness of breath because of their anemia, they will transfuse.
Thank you. And I know, Dr. Lichtenthal, you talked a lot about conflict with oneself and thoughts and feelings. What can someone do when they feel conflicted about doing something that feels emotionally hard but is important to them, such as picking up the ashes of someone who's passed away, figuring out what to do with the person's belongings, or attending an event they wish the person could be there for?
Yeah, I mean, there are so many ways that people are recognizing that there's something they might want to do, but the pain feels like it can prevent them from taking steps toward those important things. So the first thing I would say is that there is no should in any of these kinds of situations, right? There's no date that someone should pick up someone's ashes. There's no timeline when we should do something with someone's belongings. And so that permission giving and that allowance I think that's very important because others in someone's world might comment on, you should, or you'll feel better. But what the meaning of whatever that situation is to the grieving individual is very, very personal. And so we want to be mindful that other people's commentary and suggestions is for them often is kind of trying to be helpful. And what the grieving individual needs to think about is what is the meaning for them. That said, there sometimes are things that are actually really important to someone who's grieving, and it is that pain that makes it feel very hard to approach. So it's not that it's a should coming from themselves or a should coming from someone else, but it's actually, I want to pick up those ashes. I actually really want to. And so then we could think about, well, what could be scaffolding to make that easier? Sometimes that might be telling someone about it and getting support. So that might be, going to pick up ashes. Or if you say, I really, really feel like what this person would want would be to take their belongings and donate it. And it feels so hard to do. So maybe you have a companion support you with that exercise or go with you somewhere. The other kinds of things we can do, and this is where sometimes getting some professional supports can be helpful if there are things that feel bigger, or that those sets of emotions feel harder, can be things like visualizations. We can kind of prepare for some things and let those emotions kind of work their way through, and then go ahead and when we actually go to do something, it can feel more manageable. So I would say that broadly speaking, there are no timelines, there are no shoulds, but if something really does feel important and meaningful, to kind of bring in scaffolding that will help you with going to that place of pain, all the while being compassionate to that process, is one way to respond to this.
Thank you, doctor. And final question for tonight, Dr. Khawand-Azoulai. Can patients change their minds about hospice?
What a good question. Certainly, yes. So sometimes patients enroll in hospice, they're feeling lousy, their treatment had them feeling really, terrible. And then they find out from their oncologist that there's a clinical trial available to them and they're starting to feel better. They can revoke hospice and go back to full care. So I always say it's not a one-way street. I just want to add, I've been aggressively answering as many questions as I can in the Q&A. Dr. Lichtenthal, there is one for you in there if you have time to type it up before 2 minutes are up.
Yeah, thank you, doctors, for doing that. And with that, we'll start to wrap up tonight's program. To learn more about Sylvester's bereavement care services, you can visit sylvester.org/bereavement care. We also invite you to join us at the annual Sylvester Cancer Survivorship Symposium. It's on October 29th and 30th. It's an opportunity to hear more from leading cancer experts like you heard from today and survivors. You can register by visiting sylvester.org/MCSS or by scanning that QR code that you see on your screen now. We truly appreciate your participation tonight. I know those questions were coming in from the beginning. Be sure to follow Sylvester on social media. The handle is @SylvesterCancer. Please also take a moment to fill out the survey and share your feedback. That's very important to the team. And of course, have a wonderful evening and stay well. Thank you all.